ये कार्डिक डिजीज का डॉग है. कार्डिक डिजीज इन प्रेगनेंसी एंड कंजेनिटल हार्ट डिजीज. इंट्रोडक्शन. The incidence of heart disease during pregnancy in the UK has remained constant at 0.9% over several decades. However, the severity and the risk it poses during pregnancy appears to be increasing. Pregnancy में both morbidity and mortality, maternal neonatal both बढ़ जाती है. Heart disease has re-emerged as one of the leading causes of maternal mortality and is now the most common cause of maternal death in the UK. UK में maternal death cardiac disease की वजह से है. एंड हमारे यहाँ जो डेवलपिंग कंट्रीज हैं, हेमरेज इज द लीडिंग कॉज ऑफ मैटरनल डेथ. Pregnancy not only poses a risk of maternal mortality but also serious morbidities such as heart failure, stroke, and cardiac arrhythmia. The fetus is not spared. Neonatal morbidity and mortality from fetal growth retardation and prematurity are markedly increased. Congenital heart disease. In the developed world, congenital heart disease is more common in pregnant women than acquired heart disease. Developed world में congenital heart disease जो है it's more common है in pregnant women. Congenital heart disease जो है basically जैसे कि atrial defect, VSD, tetralogy of Fallot. लेकिन जो डेवलपिंग कंट्रीज है उसमें एक्वायर्ड हार्ट डिजीज ज़्यादा है. लाइक रोमेटिक फीवर की वजह से जो रोमेटिक हार्ट डिजीज हो जाता है. Among pregnant women with heart disease, the proportion with heart disease of congenital origin has rises in 2 decades from 5% to almost 80%. इतना बढ़ गया है. This reflects advances in cardiac surgery and medication, meaning that 85% of the 7 in 1,000 infants with congenital heart disease now survive to adulthood and reproductive maturity. ठीक है. Physiological changes in normal pregnancy, it's very important and it's asked off and on. During normal pregnancy, there are dramatic alterations in cardiovascular physiology, which is initiated by a fall in systemic vascular resistance to 30 to 70% of its preconception value by 8 weeks of gestation. Pregnancy में both cardiac output, जो blood volume है, बढ़ जाता है एंड जो पेरिफेरल मस्कुलर रेजिस्टेंस है वो डिक्रीज हो जाता है. तो इट्स सेइंग कि अ फॉल इन सिस्टेमिक वैस्कुलर रेजिस्टेंस टू 30 to 70% ऑफ इट्स प्री-कंसेप्शन बाय 8 weeks. ठीक है. एंड द मैकेनिज्म इज पॉसिबल फॉर सच ट्रिगरिंग वेसोडाइलेशन जो अनक्लियर बाय सेक्रेटिंग लेवल ऑफ एस्ट्रोजन, वेसोडाइलेटरी पेप्टाइड्स और फैक्टर्स such as nitric oxide and calcitonin gene related peptide have all been suggested as a possible cause. The fall in systemic vascular resistance results in fluid retention and increased blood volume. Since there is a relatively greater expansion in plasma volume, this results in a fall in hematocrit and plasma osmolality. These are basically important MCQ point of view because asked increase in cardiac output secondary to greater stroke volume, yes, and higher heart rate. And it rises to peak between 20 to 24 weeks of gestation and then it remains stable until term. तो बता रहे हैं कि इंक्रीज होता है जब कार्डिक आउटपुट, इट्स ड्यू टू इंक्रीज इन हार्ट रेट, इंक्रीज इन स्ट्रोक वॉल्यूम, greater stroke volume, and this increase in cardiac output reaches its peak between 20 to 24 weeks and then it remains stable till delivery. Arterial blood pressure falls until mid-pregnancy, gradually return to pre-pregnancy levels in the second trimester. Prolonged volume overload results in physiological left ventricular hypertrophy. Labor, particularly in second stage, associated with a further increase in cardiac output. Pain induces a sympathetic response, causing an increase in heart rate. Stroke volume is augmented by autotransfusion during contractions. Following delivery, the return of uterine blood into the systemic circulation, it results in a further increase in cardiac output. Stroke volume, heart rate, and cardiac output remain high for 24 hours post-delivery. Stroke volume, heart rate, and cardiac output, it remains high for 24 hours post-delivery with rapid intravascular volume shifts in the first 2 weeks postpartum. The later stage of pregnancy and early postpartum periods, they are of high risk of pulmonary edema. Management principles. Women with congenital heart disease should ideally have a planned pregnancy managed by a multidisciplinary team, which includes obstetricians, cardiologists, anesthetists, neonatologists, and midwives. This requires close collaboration between tertiary cardiac and high-risk obstetric services. Effective management involves pre-pregnancy counseling and risk assessment, close preterm monitoring and maternal monitoring during pregnancy, and a detailed management plan for labor and delivery in close surveillance in the immediate postpartum period. Pre-pregnancy counseling. Pre-pregnancy counseling enables the impact of pregnancy on pre-existing heart disease to be explained to the woman and the family to allow them to make informed choices. The risk to the mother and fetus should be discussed, and the likelihood of congenital heart disease in the fetus outlined. Any medical intervention, surgical treatments can improve pregnancy outcome should be considered. So these are the predictors of adverse pregnancy-related cardiac events, and these are the cardiac indications for cesarean section. So predictors of adverse pregnancy-related cardiac events. It involves all the past history, the past history of MI, heart failure, TIA, stroke, arrhythmia. So prior cardiac event, heart failure, transient ischemic attack or stroke or arrhythmia. A baseline AHA class greater than 2 or cyanosis, left heart obstruction, mitral valve area less than 2 cm square, aortic valve area less than 1.5 cm square, or peak ventricular outflow tract gradient greater than 30 mm of mercury by echocardiography. Reduced systemic left ventricular function, ejection function less than 40%. Predictors for adverse neonatal events. NEHA class greater than 2 or cyanosis during the baseline prenatal visit. Maternal left ventricular obstruction. So predictors for a maternal cardiac event are prior cardiac event, heart failure, transient ischemic attack or arrhythmias, and baseline NEHA class 3 or 4 cyanosis, left heart obstruction, mitral valve area less than 2 cm square, aortic valve area less than 1.5 cm square, or peak ventricular outflow tract gradient greater than 30 mm of mercury by echocardiography. Reduced systemic left ventricular function, this may ejection fraction less than 40%. Predictors for adverse neonatal events. NEHA class greater than 2 or cyanosis during the baseline prenatal visit. maternal left ventricular obstruction, maternal smoking, multiple gestation, anticoagulation during pregnancy. And there are cardiac indications for cesarean section, aortopathy with aortic root greater than 4 cm, aortic dissection or aneurysm, and warfarin treatment within 2 weeks. So here, labor and delivery. The appropriate timing for delivery is crucial to balance maternal and neonatal morbidity and mortality. A clear plan management for labor and delivery should be established in advance. In general, vaginal delivery with low-dose epidural anesthesia is a method of choice. This is the MCQ. Labor requires careful monitoring of both mother and fetus. Preload and blood pressure should be monitored carefully. Blood loss minimized. Women should be nursed in the left lateral position. Forceps when used, it can be used to shorten maternal expulsive efforts in the second stage. Antibiotic prophylaxis should be given in labor and delivery for all women except those with repaired patent ductus arteriosus, isolated ostium secundum, atrial septal defect, and mitral valve prolapse without regurgitation. The management of the third stage. Bolus dose of oxytocin should be avoided, as they can cause severe hypotension. Low dose oxytocin infusions are safer. Ergometrin should be avoided. In most cases, it can cause acute hypertension. Uterine compression sutures can be helpful in the management of uterine atony at cesarean section, and the safety of misoprostol is yet to be determined. Careful hemodynamic monitoring postpartum is typically required for 24 to 72 hours, but this should be extended to 14 days in women with pulmonary hypertension. Multidisciplinary follow-up should take place 6 weeks after delivery. Okay. Specific lesions and maternal and fetal risks. Risk to mother from congenital heart disease appear to be determined by the ability of her cardiovascular system to adapt to pregnancy. Different congenital cardiac lesions carry specific mortality risks depending on current hemodynamic status, previous operation, and anatomical features. Pregnancy also poses the risk of serious maternal morbidity. Okay, pulmonary edema, cardiac myas, they account for majority of events with thromboembolism. Angina, hypoxemia, infective endocarditis are also reported. Predictors of primary maternal cardiac events are prior cardiac event, prior arrhythmia, New York Heart Association function class greater than 2, 3 or 4, heart 3 or 4 it involves left heart obstruction and myocardial infarction. Low risk lesions, small left to right shunt. In pregnancy, increased cardiac output and blood volume are counterbalanced by a decrease in peripheral vascular resistance. Left to right shunting in women with ASDs, ventricular septal defects, and PDA therefore reduced. In the absence of pulmonary hypertension, pregnancy, labor, and delivery are well tolerated. Women with atrial septal defects, they are at risk of atrial arrhythmias and paradoxical emboli. As such, there is a low threshold for heparin prophylaxis. Labor needs to be managed carefully as acute blood loss or vasodilatation from regional anesthesia can affect the degree and direction of intracardiac shunting, acutely reducing left ventricular output. Coaptation of the aorta occurs in 6 to 8% of the patients with congenital heart disease. Majority of the cases are diagnosed in infancy, childhood, and either surgically corrected or treated by vasopressor or stent implantation. Women with repaired coaptation of the aorta are expected to reach childbearing age. In contrast, native coaptation is encountered much less frequently. Pregnancy is usually well tolerated in women with adequately repaired coaptation, essential to assess cardiac status before conception, excluding inappropriately managing complications such as recoaptation, aneurysm at the site of repair, and isolated bicuspid aortic valve or systemic hypertension. In both corrected and native coaptation, pregnancy poses the risk of aortic dissection and rupture and resistant hypertension. Poorly controlled hypertension can lead to adverse neonatal outcomes such as growth restriction, placental abruption, premature delivery, maternal outcomes including the preeclampsia, hypertensive crisis, and rupture of an intracranial aneurysm. As such, it needs to be tightly controlled with beta blockers, the first line agent. There is a small risk of intrauterine growth restriction with beta blockers, and beta growth should be monitored regularly and assessed by ultrasound. Tetralogy of Fallot. Tetralogy of Fallot is the most common form of cyanotic congenital heart disease, characterized by a non-restrictive ventricular septal defect, aortic aorite, pulmonary stenosis, and left ventricular hypertrophy. It was about tetralogy of Fallot. It's the most common form of cyanotic congenital heart disease, characterized by non-restrictive ventricular septal defect, aortic aorite, pulmonary stenosis, and right ventricular hypertrophy. In developed countries, tetralogy of Fallot is usually corrected surgically in infancy, well before pregnancy is contemplated, generally accepting that pregnancy in women with repaired tetralogy of Fallot is well tolerated. Complications such as arrhythmias and right ventricular failure do occur, particularly in the presence of the rejections, right ventricular obstruction, pulmonary hypertension. Many women with tetralogy of Fallot will have significant pulmonary regurgitation, and therefore they can become symptomatic during pregnancy, occasionally needing dietary treatment or bed rest. Regular cardiac review throughout the pregnancy for all women with repaired or unrepaired tetralogy of Fallot is advised. Moderate risk lesions. Transposition of the great arteries. Complete transposition of the great arteries can be repaired using mustard routing, in which the tricuspid valve and the right ventricle supports systemic circulation. Many women with corrected transposition of great arteries are on ACE inhibitors, which should ideally be stopped before conception, and they are associated with fetal nephrotoxicity and congenital malformations. Complete repair has been carried out using jetting procedure, in which left ventricle remains the systemic ventricle. The outcome of pregnancy in these women remains to be seen, but recent case reports are promising. Cyanotic heart disease without pulmonary hypertension. Cyanotic heart disease without pulmonary hypertension is caused by uncorrected transposition of the great arteries, truncus arteriosus, uncontrolled tetralogy of Fallot with pulmonary stenosis, atresia, univentricular heart, tricuspid atresia, Epstein anomaly with atrial septal defect. During pregnancy, the fall in systemic vascular resistance and a rise in cardiac output exacerbates any right to left shunting, worsening pre-existing cyanosis and hypoxia. Maternal complications depend mainly on ventricular function and include hemorrhage, paradoxical embolus, heart failure. These effects on the fetus are marked high incidence of spontaneous miscarriage and a 30 to 50% of premature delivery or birth weight. The degree of maternal hypoxemia is the most important predictor of neonatal outcome. Admission for bed rest, oxygen therapy, effective method of maintaining maternal oxygen saturation and fetal oxygenation and growth. Fontan procedure has become recognized definitive procedure available for complex aortic heart disease that drive a single functional ventricle atrial separation device with systemic endopulmonary circulations and with the construction of the atriopulmonary connections where enters the pulmonary circulation without versatile ventricular flow. Increasing numbers of women frontal circulation are reaching childbearing age. The main concern regarding pregnancy is the ability to augment, maintain, and adjust the cardiac output and the heart rate. There is also a tendency towards atrial arrhythmias, which are poorly tolerated. Maternal risk of pregnancy are low in NEHA class 1 to women provided ventricular function is good. High risk lesion, Marfan syndrome, inherited disorder of connective tissue, the risk of thoracic aortic aneurysm leading to aortic dissection, rupture of both is increasing with pregnancy. This is the result of hemodynamic stress and is dependent on the aortic root diameter. With an aortic root smaller than 4 cm, overall maternal mortality during pregnancy is 1%. This increases to as much as 25% of the aortic root diameter expands beyond 4 cm. In this situation, pregnancy should be postponed until aortic arch replacement. In the event of an unplanned pregnancy, the option of termination should be discussed. Aortic root diameter should also be monitored throughout pregnancy with serial echocardiogram if aortic root dilation occurs. Prophylactic beta blockade is advised and hypertension should be treated aggressively. Pulmonary vascular resistance, pulmonary vascular disease. Pregnancy in the presence of pulmonary hypertension of any cause remains high risk. Fixed pulmonary vascular resistance prevents any increase in pulmonary blood flow matching the increased cardiac output. Pregnancy is poorly tolerated with the risk of worsening cyanosis and hypoxia, arrhythmias, heart failure and death. The majority of complications occur at term during or during the first postpartum period. Maternal mortality depends on the underlying cause with 36% maternal mortality in Eisenmenger syndrome, 30% in pulmonary hypertension and 56% in secondary pulmonary hypertension. Women should be advised of this risk when contemplating pregnancy. In the event of an unplanned pregnancy, a termination should be offered. Those who elect to continue require close cardiovascular monitoring and bed rest from the third trimester with monitoring for up to 14 days postpartum. Fetal morbidity, mortality are considerable with premature delivery and restricted fetal growth occurring in 50% of the cases and only 15 to 20% of pregnancies reaching term. Anticoagulation, oxygen therapy, pulmonary vasodilators, nitric oxide and prostacyclins they may improve the outcome. Neonatal outcome, the rate of neonatal complications significantly increased for women with heart disease. They include preterm birth, being small for gestational age, respiratory distress syndrome, intraventricular hemorrhage, and death. Many predictors of adverse neonatal outcomes are obstetric risk factors, multiple gestation, smoking, and anticoagulation. The children of mothers with congenital heart disease that also increased risk of inheriting a congenital heart disease. Overall risk of inheriting progenitor cardiac disease is quoted to be 35% compared with the 1% risk in the general population. The risk is in fact dependent on the parent's condition, being 3% in common conditions such as tetralogy of Fallot and as high as 10% with atrial septal defect, coarctation of the aorta and aortic stenosis. Marfan syndrome is an autosomal dominant condition and therefore has a 50% recurrence rate in the offspring. It's an autosomal dominant, it's also an MCQ. Conclusion. Cardiac disease in pregnancy is the leading cause of maternal and neonatal morbidity and mortality. Heart disease now accounts for the majority of disease. Effective management is based upon pre-pregnancy counseling and risk assessment, close monitoring, and maternal monitoring during pregnancy. I detailed a management plan for labor and delivery, close surveillance, and the immediate postpartum period. This was all about the talk on